Good evening. Thank you very much for turning back to our channel. I'm Dr. Dan Eli. I work with Bloom Women Health. Today, I want us to discuss with you a subject that I encountered quite common in my clinics of last week. I got so many cases of infertilities, mainly female. There are common causes of, there are very many causes of female infertility. Usually, when we get a couple or a client, because in most cases it is the women who come to the clinics, we want to try to tease out possible causes of female infertility. Number one, we want to make sure that we make a clear definition of what infertility is, because at times some people, maybe immediately after they are married or when they have just met, they at times imagine that they should be able to conceive immediately. So for us to be able to make a clear diagnosis of infertility, a couple should be having regular unprotected sex for at least about a year for us to be able to make a very good diagnosis of female infertility. Female infertility generally is a very widespread issue. It does not only affect the women. Actually, there is also a good proportion, close to 40% of infertilities resulting from male infertility, and another 40% may be female factors, and then maybe 15 to 20% may be both couple being affected in one way or the other. Regarding female infertility investigations, we broadly want to tease out about three major issues. That is, we want to investigate about the ovulatory factors, we want to rule out tubal factors, and we want to rule out uterine factors. Because if you function in one area and you have a gap in another, you will not be able to conceive. Regarding ovulatory factors, generally we anticipate that any woman who is below 35 years and is having regular cycle should be having normal ovulatory pattern. So if I get a client who sees her periods every month and she's below 35 years, it is extremely very unlikely that she has an ovulatory problem that could be delaying her conception. And regarding ovulatory factors, there are so many conditions that can lead to ovulatory factors. Ovulatory factors arise if somebody is not able to see their periods, or if they are not able to see their periods regularly, the cycles keep on changing. All those can be pointing to ovulatory factors. One of the trigger factors you should be able to see is if you get a client more than 35, actually 40 years in most cases, just know that there's a possibility that the ovarian function could be declining. And there are many causes of ovulatory defect causes. One of the commonest causes is hyperprolactinemia. There are ladies who generally do not see their periods because the brain produces a very high levels of milk hormone, the prolactin. Prolactin is mainly high levels in breastfeeding mothers, and that's why you realize that those women who are breastfeeding do not usually see their periods. So we always want to try to investigate if there's any problem with the levels. If they're so high, we usually give medicines to be able to reduce the levels. Also, there are other hormones like thyroid hormones. So whether it is hypothyroidism or it is hypothyroidism, it's the same problem. You find that it can, since thyroid helps in metabolic function, so if there is either hypothyroidism or hypothyroidism, it will be able to affect ability for other hormones to be able to be secreted in adequate quantities. And then some women have a condition which is very common. We call it a polycystic ovarian syndrome. Usually for you to be able to make a diagnosis of polycystic ovarian syndrome, the mother should be able to meet 3 criteria. The first is that she should have irregular menstrual dysfunction. Secondly is that she should be having features of hyperandrogenism. That is, if a lady has features, male features, either is having excess hair in the body, or she's having acne in her body. So at times that may be, or it may not be a physical symptom, but it may be that when you check for the testosterone levels, male hormone levels, you find it's a bit more higher than what is anticipated in women. So generally that is how we make a diagnosis. So out of the 3 features, somebody should be able to have 2 of them, and of course the third being, if you did ultrasound, you'll find that the woman has very many cysts, and there's a particular criterion for you to be able to say that it's a polycystic ovary. Not just every cyst qualifies somebody to have a polycystic ovarian syndrome. And then there are some women also who get what is called premature ovarian insufficiency. Premature ovarian insufficiency means that the ovaries kind of fail to function, and this diagnosis we usually make if a woman is 40 years and below, and probably she is not able to see her periods well, and when you measure the hormonal function, there's a destabilization, or they don't able. So in a way that can be caused by so many things. Oftentimes it can be that somebody probably who had undergone through maybe chemotherapy, we need to be able to rule out that. You take a good history. If a person has had any surgery, maybe in a pelvic surgery or surgery on the uterus, at times during the surgery, doctor probably could have cut or disorganize the blood supplies to the ovary. In a situations like that, somebody can have a premature ovarian insufficiency. So those are generally the common conditions that present in patients with the ovulatory factors. So usually for you to be able to detect that, you need to do hormonal assays. You need to do levels for follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone. You want to also know about prolactin levels. So usually the diagnosis is individualized. So that's what happens when somebody is having a premature ovarian insufficiency. So the second issue usually we try to tease out as a female factor infertility are tubal factors. Tubal factors happen if the tubes are blocked, and tubes are blocked mainly because of infections. So if a lady probably has had history of abnormal vaginal discharges, I know when you have a discharge down in the cervix, it goes into the uterus, into the tubes, at times in the pelvic area. And when these tissues heal, they heal with kind of adhesions, and because the tubes we're dealing with are extremely very narrow, so there's a scarring within the tubes, and that affects the tubal function. So usually you may at times need to take a history of previous pelvic infection, and to be able to rule out this. Another condition that commonly causes a tubal blockage is endometriosis. Endometriosis is a condition which is like which is a very complicated condition, because once there is endometrial tissue, it can be located anywhere. It can be in the tubes, it can be in ovaries, where it also causes a lot of infertility issues, or it can be within the uterine muscles area. So if it is within the tubal area or within the pelvic region, it is common that people get some kind of adhesions within the tubes. So usually what you need to do is to be able to do investigations that can be able to, for you to be able to detect if a woman has tubal blockage. And the commonest usually in most of our facilities is hysterosalpingogram, which in reality is a test that is extremely not very specific. It is only useful if the tubes are patent. But if a tube is blocked, it may not necessarily mean that it is blocked. And then the third common problem causing female infertility usually is the uterine factor. And when we talk about uterine factor, there can be congenital or acquired. Congenital factors are mainly common in patients who a client who has never conceived before. Because at times in the formation of the uterus, some people have uterine abnormalities. Either you can have a unicornate uterus, you can have a bicornate uterus, you can have what is called a septate uterus. And when you have an abnormality in the uterus, it becomes extremely very difficult for you to be able to conceive. Even if there's fertilization, at times there will be no implantation within the uterus, and therefore they will think that you're not conceiving. So every time you're investigating people, you should be able to rule out a possibility of that. But this is more common, like the congenital abnormalities are more common in people who had never conceived before. And then there are acquired causes of uterine factors. For example, things like fibroids, which happen in a very big proportion of women. And because fibroids are so common, you cannot generally say that if somebody has fibroids and then it will cause infertility. Usually it depends on the location of the fibroids and the sizes of the fibroids. If fibroids are more than 4 centimeters and they are multiple, at times they can be able to affect the uterine function, either the motility of the uterus or the implantation process. And also in some situations when you have a huge fibroid located in the corner, we call it a uterine conure, where the tubes emerge from, it can be able to kink that area, and then therefore it will close the tubes, which makes it very difficult for sperms to move towards the ovaries for fertilization to be able to take place. So basically those are the three broad areas of causes of female infertility. So the investigations for these are usually very simple, but when we are doing the investigations, we have to choose according to the patients, because we cannot just assume that every patient has this particular problem. So we need to individualize the investigations. So for uterine factors, the commonest investigation usually we do is just to do a pelvic ultrasound. It can be able to tell us if the uterus is normal, if the fibroids, if the endometrium is visible. If we're able to get the basic information like that, that should be sufficient. And then for the tubal factors, as I said, we have a hysterosalpingogram. It's a HSG. It is a test where a dye is passed through the cervix using a tube. You push a dye through the cervix and then the pictures are taken. And at the end of it all, you want to see that there's a spillage, that the dye you've passed has emerged out of at the end of the tubes and is freely flowing in the abdomen. So that can be done. Although the gold standard for tubal investigation is hysterosalpingogram, because it's real time. What happens in laparoscopic chromatubation is that the doctor will be able to push in a camera through the abdomen of the lady, and then down through the cervix a dye is passed, and then with the aid of camera you'd be able to see the tubes real time and see that yes, the dyes are emerging in both tubes, and that way you'd be able to to know. And another important thing about laparoscopic chromotubation is that when you do it, you will be able to know if this tube is easily repairable or not, because when you do hysterossalpingogram, you're taking pictures from outside, so you cannot clearly understand how the actual tubes looks like. So at times when you do laparoscopic chromotubation, it is easier for you to be able to understand if the tubes are easily repairable or not. And another thing you need to know is that if the tubes are usually blocked very close to the cornea at the angles where the tubes emerge from the uterus, usually it's extremely more difficult at times to repair such tubes. At times, for you to be able to repair them, you may need also to do another test we call hysteroscopic cannulation, which we'll be able to discuss in the subsequent management when we're managing the cases of infertility. And then finally, as I said, for the ovarian functions, mainly we do hormonal assays, and that is the way we make a different diagnosis of female infertility. If you have been having trouble trying to conceive, you don't have to be worried. In this age, we expect every woman who needs to have a child to be able to have a child. Yesterday I delivered a woman who is 51 years, although she conceived through IVF, but all the same, somebody can be able to conceive with support of hormones and this kind of things. And then we'll be able to talk to you about the best management plan that can help you to conceive. Ladies and gentlemen, if this is your first time to tune to our channel, please, I would request you to like this video and also share it with whoever you think can be able to benefit from it. And then you should subscribe to the channel, and that way we'll be able to increase the numbers of viewership, and then the materials will be very useful to so many other people. In the next video, I'm going to discuss with you how we manage female infertility in details. Stay tuned. Thank you.